Hello everyone. Today we are going to talk about acute myocarditis. Myocarditis is inflammation of the heart muscle, and it can be caused by a lot of different things, which means it has a lot of different potential presentations, ranging from acute to chronic inflammation with focal to diffuse myocardial involvement. Now, acute myocarditis is defined as a condition with symptoms of heart failure over 3 months or less. And the history of this acute myocarditis is highly variable. There are no defining symptoms on presentation. Now, in about 40% of cases, there is a viral prodrome that you can expect, your typical fevers, myalgia, just feeling generally ill because these acute myocarditis is caused by viral infections in about 40% of cases. Now, things you can ask about are fatigue and decreased exercise tolerance. They sort of fit into the viral prodrome, but just into the other infectious and systemic pathologies that can cause this as well. On physical exam, you can see tachycardia out of proportion to fever. So if they do have a fever, their tachycardia, which is usually going to be sinus tachycardia, will be way higher than their fever should make it. You can also look for signs of heart failure because, again, this is a condition with symptoms of heart failure, so you can look for your JVD, peripheral edema, rales on auscultation, any new murmurs. And then this can also have components of pericarditis, where you might have this chest pain that you would classically see in a diagnosis of pericarditis. Because there is high variability in patients who present with acute myocarditis, you'll want to keep an appropriately broad differential, but you'll want to include all the life threats that can happen in the chest. So take a moment to pause here and think through how patients with each of these would present and sort of compare them to acute myocarditis and see how they stack up. Also, it's important to keep in mind that these patients might have systemic rheumatologic problems that's causing their acute myocarditis, and you'll need to rule out anemia because on the less severe end of the spectrum with these patients, they might just have anemia that's causing them to have fatigue and just be generally more tired. As always, our diagnostic testing should fit the differential we made, so we're going to want to get a troponin, a BNP, a CRP and ESR, a CBC, and a CMP. Now, the troponin might be elevated in acute myocarditis, so it's important to compare that with an EKG to look for signs of ischemia. If ischemia is present and they go to the cath lab, these patients will likely have a clean cath report, but it doesn't mean that you did the wrong thing by activating the cath lab. Now, the CRP and ESR are both inflammatory markers, and though they have high sensitivity, they're pretty much elevated in most inflammatory conditions, so they're not super sensitive. Now back to our EKG, sinus tachycardia is going to be the most common rhythm, and atrial arrhythmias will be the other rhythm that you might see in these patients. Most of the time they are asymptomatic, but it's just something to be mindful of. Now, if you get a chest x-ray, which I think is a good thing since pneumonia and stuff like that's on your differential, you will probably see signs of fluid overload if the patient is symptomatic. You will most likely not see an enlarged heart or anything like that because this is an acute process. Now, if you get a point of care ultrasound, if you do an echo, you will see reduced ejection fraction, focal wall motion abnormalities, and potential left ventricular dilation. And if they have a component of pericarditis, they might also be developing a pericardial effusion. So you have some time in between patients, so you go put the ultrasound probe on this person and get this good apical 4-chamber view, and if you were to measure the flow, you would see that this demonstrates moderate to severely depressed ejection fraction, and you can sort of see from this echo that they have global hypokinesis, and because there is no ring of hypoechoic fluid around the heart, we can determine that this person does not have a pericardial effusion. Management of acute myocarditis can be pretty tricky and of course depends on how they present. We're going to focus more on the severe end of the spectrum, which means we have several things to consider. We're going to start with IV loop diuretics and ACE inhibitor therapy. We're also going to want to see if this patient is on beta blockers. And if they are, we're going to want to stop them from taking those, but it's a good thing to have in mind as we move forward because if they start to have increasingly reduced ejection fraction and worsening of symptoms, developing hypotension, all that, it's time to start this patient on inotropic support with dobutamine. But if you are on beta blockers, dobutamine is not very effective. So in patients who have chronic beta blocker therapy, we're going to want to start milrinone. Now, warning for this is milrinone, which is a PDE3 inhibitor, is a potent vasodilator. So if you give this to a patient with hypotension, you can expect that hypotension to get worse even if the ejection fraction improves. On the opposite end of the spectrum, you can consider epinephrine, but this is a potent vasoconstrictor, so this might actually, though giving pressure support, make the ejection fraction worse. The next line and the last line is mechanical circulatory support with a left ventricular assist device or ECMO. Again, this is after you've exhausted all of your medical options, you can consider these. Now, a caveat to this is you might, whenever you do your echo, see that they have a lot of fluid around their heart. And in this case, you would perform an emergent pericardiocentesis to drain that fluid because cardiac tamponade is no joke and can kill your patients very quickly. All of these things are a little bit beyond what you might be doing at the medical student level, but it's good to present in your plan if you truly think your patient has myocarditis, that you're thinking about these things down the line of basically precautions to take in case your patients get worse. So the disposition for these patients on the surface seems pretty straightforward. If there is a concern for myocarditis, the patient should be admitted, and that's pretty much it. Now, the next question is, where should they be admitted to? Some of these patients just need to be admitted for more short-term observation, where we're just making sure that their symptoms don't get worse and that they're not going to develop an effusion if they are at risk of concomitant pericarditis. On the other end of the spectrum, these patients can be really sick and on multiple pressors. So the patients on that end of the spectrum would be headed to the ICU. So this is one where you're going to just really use your clinical judgment to see what sort of resources these patients would need once they're admitted. As we wrap up, it's time for some fast facts and practice pearls. First, viruses are the most common pathogens responsible for myocarditis. There are lots of other causes, but viruses as a group are most likely. There is not a single red flag or magic question you can ask these patients. Rather, you just need to take a broad history that really sums up why your patient is presenting to the emergency department. This will be good for moving things around on your differential and just getting a good picture of why your patient's here. Next, it's recognized that myocarditis is a frequent cause of sudden cardiac death in young people. In fact, up to 20% of young adults who have sudden cardiac death is attributable to acute myocarditis. Finally, it's commonly quoted that myocarditis is the most common cause of acute heart failure in patients less than 40 years old. So, whenever you're developing a differential for a patient who fits that epidemiological category, you will want to have this high on your differential and use this statistic whenever you're presenting to really drive home that part of your presentation. Myocarditis is a little bit more rare than some other things that we have talked about, but it's also likely underdiagnosed. So it's something that you should be familiar with because you can put it on lots of differentials for patients who come into the emergency department. So it's at least good to know why you're putting it there and how you should test for it. I learned about acute myocarditis from these resources, and I think they would be a great place to start if you want to learn more about it as well. As always, thanks for listening.